So, with everyone's permission, I'm starting with today's live now. Greetings and a warm welcome to all the dignitaries present here. I'm Shwastika from Team Clearnet, serving as the allocated session assistant to ensure a seamless experience. Clearnet is India's most trusted and widely used digital platform, offering a multitude of engineering services exclusively for the doctors. Clearnet is slated to be chosen as a digital partner for this event organized by Indian College of Anesthesiologists. So today's focus would be from theory to theatre, practical TCI TIVA mastery. Let's begin today's session, for which I would like to invite Dr. Manjula Sarkar ma'am to take over. Over to you, ma'am.
Thank you, Swastika, for handing over the session to me. As you said that today's session is on TIVA, TCI. And on behalf of Indian College of Anesthesia, I welcome you all the present dignitaries, Dr. Monteiro, Dr. Nitin Sethi, Dr. Sanish, Dr. Vineet, and Dr. Subramaniam, and Dr. Shilpa Tiwaskar. As all of us are aware that Indian College of Anesthesia is doing lots of work to just give the advantage not only to students but all the private practitioners, those are practicing in anesthesia, and all the fields wherever the mastery is needed, and from subspecialty to super specialty, that Indian College of Anesthesia is really doing a good work for that. And for the benefit of students, I would like to announce that Indian College of Anesthesia has a deal with American Society of Anesthesia also. And for this year, they have reduced the annual membership fees for the students so they can go and take the experience of anesthesia in the international level. So I welcome you all once again. And I'm beginning the session with this with this welcome address. So today's session is going to be Dr. Shilpa Tiwaskar is going to be our co-moderator. And as you know that she's a dynamic lady, she's very enthusiastic, doing lots of work for anesthesia. So I welcome Shilpa for this session with me to you also. Now, the first panelist of the day is Dr. Joseph Monteiro. He is, can you show me his slide, please? Yeah, he is working at present at PD Hinduja Hospital and Medical Research Center, Mumbai, India. He is consultant as a neuroanesthesiologist, program director for DNB, neuroanesthesia and neurocritical care, scientific research committee member 2. Areas of interest are neuroanesthesia, neurocritical care, airway management, teaching and training, research and publication, as all anesthesiologists credits are there. Publications are high index, high citation rate, chapters, guidelines, review articles, reports in international, national textbooks and journal, and many awards in his credit. So I welcome Dr. Joseph Monteiro for this webinar. Now I hand over the mic to Dr. Shilpa Tiwaskar for introducing other panelists for the day and begin the session.
Thank you so much, Manjula Sarkar, madam. So it's a privilege to introduce our next panelist. Okay, my slides are moving. 1 minute. Just escape. Yeah. So our next panelist is, again, same slide. Yeah. Dr. Nitin Sethi, sir. Sir is senior consultant at Sir Gangaram Hospital, New Delhi. Sir's areas interest are anesthesia for laparoscopic and robotic surgery, interest in liver transplant and GI and hepatobiliary surgery, in monitoring the depth of anesthesia and total intravenous anesthesia delivery systems. Sir has publications and awards to his credit. Sir has JSA Baxter Scholarship 2010, the NWAC Educational Scholarship and ICMR grant in 2013, Appreciation Award for Teaching and Training in Field of Anesthesiology by ISA Delhi branch in 2022, and Sir has more than 26 indexed and 20 non-indexed publications and 11 book chapters. We welcome you, sir. And it's again a privilege to introduce our next panelist, Dr. Subramaniam Mahankali, sir. Sir is Senior Consultant at Krishna Institute of Medical Sciences, KIMS, Bengaluru, and Regional Director of Anesthesia Services. Sir's interest is in regional anesthesia and solid organ transplantation, total intravenous anesthesia and patient safety. Sir's interest is in POCUS and obstetric anesthesia and anesthesia education and simulation-based training, perioperative management, integrating digital technologies and AI in anesthesia and OT. So the most recent topic. Sir has a lot of publications and awards. Sir is one of the first certified digital health professional in India, has more than 20 publications in peer-reviewed journal, 2 chapters in Yearbook of Anesthesiology, 5 chapters in Textbook of Anesthesiology, is a founder president of Association of TCI and TIVA Anesthesiologists. Sir is a member of BOSS AORA and Executive Committee of AORA and delivered more than 50 talks in state, national, and international conferences and in faculty in more than 30 workshops. We welcome you, sir. Over to you, Manjula, madam.
Thank you, Shilpa. So, to begin with the session, I would like to say that in this era of anesthesia, with high technological advancement, the things has changed drastically. In the past, the people were aware about anesthesia is chloroform सुंघा दिया तो बेहोश हो जाते हैं. But now the things that people are, even patients are asking lots of questions from us. So we have to be really update ourselves. And today's topic is on the TCI and TIVA. So first question I would like to ask Dr. Nitin Sethi, that what is the need of TCI in this era? And why not only TIVA or TIVA with BIS? So what is the principle behind this? Can you just give the explanation regarding this?
Yeah. When we when we talk about TIVA, when we say total intravenous anesthesia, it's basically a broad term, basically giving anesthesia by the intravenous route, to put it very simply. So
Correct.
the methods of giving TIVA. So why TIVA came? TIVA came because now, if you look at the current scenario, the main buzzword is environment. So okay, it is one of the main advantages, like it's environment friendly when you compare with other inhalation agents. Like there's a lot of thing, especially going on in the European world, a lot of recommendations coming from, they are sort of giving up on inhalation anesthesia. Obviously, other advantages like reduce incidence of PNV, decrease incidence of post-operative delirium, and obviously the current research suggests that TIVA has, like with propofol, has a good anti-inflammatory, and it has a anti-neoplastic effect also. Obviously, that is still being debated, and obviously useful in various areas, like when you are doing a neuromonitoring, or when you are needing in non-operating room operative settings, or you want to do a tubeless surgery, like in tubeless microlaryngeal surgeries, or tubeless mini VATs, and also these are various applications for TIVA which are coming up. So when we talk about TIVA, it is not only giving through you can give it either through a manual infusion pumps. You can either use a target controlled infusion pumps, which are a more refined or more automated microprocessor linked pumps, which utilize the pharmacokinetic and pharmacodynamic models of the intravenous agent we are using. And obviously, of late, not available everywhere, but automated closed loop systems have also come, and we have one in India also, which is now being commercially available also, which I believe in times to come will be, when we are talking about AI, will be in a lot of OT theaters. We currently are using one for last 10 years now. So the basic principle behind TIVA is you have to understand the pharmacology, the distribution pharmacokinetics. So when we talk about TIVA, it is basically a multi-compartment models. So basically, the drug goes into the central compartment and then is distributed to the peripheral, the rapid and the slow equilibrium compartments. And now what we talk about is the effect side compartment, the brain. So all the current drug models which are coming are targeting the effect site concentration. That is the concentration at that which is achieved in the brain. So all the new models, whether it's like the Elved model or the Schneider, which is the pure effect side model, and the modified Marsh model. So various models are available which can be used, and you should have proficiency in any one of these models. You should be using regularly in your practice. Any one models you can use.
So thank you, Dr. Nitin. But if we look in the past, then in the past also we were giving total intravenous anesthesia. I still remember in 85, 86, the people were just putting pentothal in 250 ml of normal saline and giving TIVA. But at present, we have the advantage of all advanced monitoring and infrastructure available. So we are
Yes.
just doing precise and accurate anesthesia with the help of TIVA, because in the past it was creating lots of problems, and just it was not very much acceptable by all the anesthesiologists. So
True,
this
ma'am.
is the advancement has come in this way. This is
Even
what.
these systems are now cheaper. Now, earlier it was a closed loop, closed system. Now, with the
Correct,
open TCI
correct,
concept,
correct.
now every company is manufacturing it. The cost has come down. But one thing which, when we talk about the manual infusions, is the concentration achieved is not very appropriate, which is to the surgical stimulus which is required. With
Correct.
target controlled infusion, they are microprocessor controlled. They have that software which is incorporate the drug model. So your concentration achieved for targeting the desired surgical effect is more accurate, and more you can more rapidly achieve that concentration. And obviously it has to be done with monitoring. If you're giving TIVA or you're using TCI or anything, you have to have a depth of anesthesia monitor. Otherwise you won't know what anesthesia depth your patient is. So having the right equipment is very essential for practicing TIVA. That's what it is.
TIVA
So,
total
just like,
intravenous.
thank you very much, Dr. Nitin, for that excellent answer. I would just like to add on to this specifically to neuroanesthesia. So, if you see the chart, all IV anesthetic agents and opioids, they decrease the CMRO2 and they decrease the cerebral blood flow. So they have this commonality where they reduce the CMRO2 and reduce the cerebral blood flow. This helps to give you a good neuroanesthetic, because that is what we desire. Propofol is also a very good cerebral vasoconstrictor. So there is another ideal drug to use. All inhalational agents produce a dose-dependent vasodilatation in different phases. So it's ideal, especially in certain situations like in a tight brain. Then it is preferable to, if you have started off with inhalation, it is best that you switch over to a TIVA technique in neuroanesthesia. And specifically, if you know preoperatively that this patient has got a raised ICP or a chances of the brain bulging, then it is best that you stick to the intravenous technique. As Dr. Sethi has mentioned very nicely, that actually in European countries, they have been doing TCI, TIVA since 1998, since the time while I was there. And it is the American group that has focused a little more on the inhalational side. So if you see, industry also has been driven similarly. So you can see the environmental issues that are being raised. They are raised more in Europe than in America. I don't know whether it's something to do with from where those drugs are being manufactured, but we must keep that also in mind. If
So
we speak
thank you,
about the
Dr.
TIVA
Joseph.
we
That
used
means
many
that
years ago, madam, that was a very rudimentary style of giving it. We have all done it. But now, as you said, it is all AI driven, AI generated. There is a closed feedback loop, which was not there in those days.
so in more specific conditions and for more special cases, it is more beneficial, we can say, and it is more accurate to give the drugs and come out, patient will come out, give the better results and outcomes are good, correct? So
Yes.
now I hand over the mic to
Madam,
Shilpa.
can I come in?
Please,
Yeah,
you are
please,
most
please.
welcome.
Ma'am, just to reflect as a group or thing. From 1997, when I started my PG to now, I have not heard of a new volatile anesthetic agent just come into practice. No advanced science is being put into that. But on the other side, you look at how many drugs were coming and the reason why they're coming in. We have gone and understood the pharmacology in so much detail that no other specialty is adopting. For example, we are in a unique specialty. For example, we want the effect to come quickly when we induce, At the end of the surgery, we want drug patients to wake up very quickly. And in between, there is various grades of stimulus. When such quick onset is required, the depth needs to be altered so quickly. And at the end, we want to wake up. We have a unique combination. So that is why the IV drugs, the latest drugs, which are easily metabolizable, easily titratable, and understand what is the difference in this patient, how I can modify. So these are the advantages which have happened in the last 25, 30 years. And that is why I see TCI is becoming very popular. Because, for example, I will give you an example. Let's say if you want to have, let's say somebody has an infection in pancreas. What do you want to do? You find the antibiotic and give the antibiotic. 1.5 grams typical dose is there. Now, we all know what is important there. The concentration of the antibiotic is important because we know MIC. Now, the same thing was applied in anesthesia. It was targeted as plasma. Then we understood, no. The drug is not working in the plasma. It needs to go to the pancreas. So the same thing in the brain, we have an understanding. What are all the different parts of the brain? The anesthetic needs to seep in and work. And we have a reflection. What is the level required for sedation? What is the required for deep anesthesia? And what are the variables which are incorporated into this? So what obvious variations can be there? We have understood it's not just the weight or how they appear. We want the weight. That is very important consideration. We want the height. We want the gender and the age. All these are incorporated and advanced models have been developed. That is the reason why TCI is becoming popular. It's just a matter of time. We already are using IV drugs for many things. We use every patient induction of the drug which we use is IV drug. We maintain painkillers by IV, opioids. We maintain muscle relaxation by IV. And we want to use the 50-year-old medicine as volatile agent because we are familiar. So what I feel is, yes, there are roles for volatile also. There are roles for total intravenous anesthesia also, especially as TCI. So I passionately feel that enough understanding is there for us to use it very safely, and it needs to be trained. It doesn't come because I use once a bolus doesn't mean that I know how to use it. We all need to get trained, reword it, relearn, and share this knowledge with people so that we can use it very safely. Thank you.
Thank you, Dr. Subramaniam, for giving your good explanation regarding these TCI pumps. And we have not only improved our knowledge, but it is us to accept the present scenario and accept the techniques and learn and proceed further.
Yes,
so we should not just stick to the old models. Now, Shilpa wants to ask something, please.
Yes, yeah. Yeah, so I'm very curious. Now, in this, for some reason, my slide is not moving. So I would like to ask, I see that there are different models for using propofol or for dexmedetomidine. So I would like to ask Dr. Joseph, sir, which model do you use? What you do prefer? Suppose you're starting a neuro case. Also, there are many questions in my mind, When I started using 2 years back, initially I used right from induction. Then I saw that suddenly the drug is going very fast. Then to achieve that plasma level or to achieve that effect site concentration. So then I stopped using plasma level. I started using effect site concentration. So from Joseph sir, I would want to know what type of models do you use for propofol or say for other type of drugs, dexmedetomidine or fentanyl, remifentanil. We use a lot of remifentanil also.
So, thank you for that question. Now, see, when we talk about models, it depends upon what you have available in your institution. So I'm not comparing it, but in a way you can compare it to a motor vehicle. Now, whether you have a Maruti or whether you have a Mercedes or whether you have a BMW, or it depends upon what you can afford to have in your institution, in your setup. So you must have a little pragmatic view. So initially, this system has been evolving. So initially, we all started off with the Marsh model. And it does, and so I started off with a Marsh model for propofol. The Marsh model, what it does, it gives a little bit of a large bolus in the beginning, so you get a effective plasma site concentration. Okay, it is like almost injecting the drug yourself, and then it slowly. But the variables, or the core variables that you enter, was only age and gender at the most. But then we evolved on to Schneider, which is more specific because you can add some more what we call allometric variables. It depends upon the body size and the concept. So now, if you're using it in an obese patient or in extremes of age, then you want some little more fine control in your system. So I moved on to Schneider. Now, I've never, and then you can, for remifentanil, I use the Minto model. But now all these things have evolved. And if you have a pump, TCI pump that has got the elevate model, it is better. You'll be little more comfortable because it has got the newer pumps have got all the models.
Okay.
So when you are buying a pump, best is you choose a pump that has got the maximum number of models, so that you can choose the drug which you want safely. The idea is to reach from point A to point B safely. It doesn't matter which model you use. Finally, it is man or woman over the machine. So don't think that this is a system where you can start it off and just put it on autopilot mode. So very often when I travel in an aircraft, I get a little worried when I see the pilot going to the washroom because the plane is flying by itself. But you have to not lose total control over the system. You should be in the system because there also, you know which parts of the surgery are a little more painful, where the blood loss is actually occurring. So the drug that you're giving, going into the plasma, may be draining into the blood that you're losing. So those calculations are algorithmic and they are built based on the Caucasian population. So not many of these algorithms are based on the Indian sort of subset. So we must know that whichever model you use, you must adapt it locally to your patient population. So I would just to make it very simple. There is no, but I will just say whatever model you use,
So
start low and go slow. When you are starting off first, there will be many people who try to frighten you, or you'll be little unsure of yourself. So always start slowly and progress gradually as you're using a new technique. So I started off with MASH for propofol.
We have to use plasma concentration. Sorry to interrupt, sir. We have to set in the plasma concentration or the effect site concentration.
I go for the effect site concentration.
So I was wondering why at all they have kept plasma site concentration in the model. Like why we need to know, or it is just for us to understand.
No.
I think Shilpa,
initially, initially you may have to, you can start off with the plasma site concentration and you can move on to the effect site concentration later. Any drug that you use, ultimately you have to see that it is acting at the site which you wanted to act. Dr. Subramaniam has said, finally, if I wanted to act on the brain, so I want to know whether it's delivering the dose which I require to maintain some sort of hemodynamics and a BIS value. So it is not about what you have to also keep a watch on the patient, the hemodynamics, the BIS value, as well as those whatever plasma site or effect site concentration. Don't go by only the numbers. And when you're using a TIVA TCI technique, you must change a mindset where you stop dialing that vaporizer and you're now switching numbers and doing some little mathematical changes of the numbers that are punching into the machine. So that mindset has to change.
Yeah, here I'm sorry to would like to point out. We recently did a study which we are just just writing the manuscript, where we compared the Schneider model, the Marsh model, the manual infusion, and the closed loop anesthesia delivery system, the one which has been developed by Professor Puri at PGI Chandigarh. So what we found was the anesthesia depth consistency was like between CLADS, Schneider, and manual median was 87%. With manual, it was 79%. The anesthesia depth consent means the percentage of time the BIS was within plus minus 10 of the target BIS of 50. So what I mean to say is, whatever you're using, if you're using it diligently, the outcome won't matter much. Because in my practice, it is like you have to have an EEG monitor, whatever processed EEG you are using. And if you're titrating your anesthesia according to that, your values, because if you look at Indian population, mostly I know you all are practicing, you don't require concentration more than varies between 2.5 to 3.5. Rarely you will be going above 4 to maintain adequate anesthesia depth. I think even they have got Dr. Puri developed what they called as the PGI model, which was based on the data from Indian patients. And I think therein they found that the concentration required in Indian patients was around 2.5, 2 points roughly, which I remember. Yeah.
Yeah, so while using this effect concentration, actually Dr. Subramaniam sir also wanted to add something, sir.
Yes, I mean, there are two things here. Whenever we feed the patient demographics into the model automatically calculates what is V1, what is V2, what is V3, and what is the constant. And it can estimate what is the level in the plasma. But there is again a constant from the plasma to the effect side. There is a lag in the brain concentration, right? So there is a lag from the time the plasma concentration is achieved to the concentration in the brain. For example, it might come to your brain, but it may not be in your pocket to use it. So that is the analogy which I can give you. But what I generally is achieved is, if you start as a plasma site targeting, the concentration in the plasma will never go up beyond it. For example, if you said 2, the plasma concentration will never go more than 2 at any point of time. It takes a long time for the concentration to reach that level in the brain. That is a lag of maybe 1 to 1.5 minutes. But if you set effect site targeting, which is what we normally do for most of the patients, hemodynamically stable patients, the mandate for the machine and the model is get the plasma, the brain site concentration as quickly as possible. So what generally happens in most of the machines is the plasma concentration shoots up by 2 to 3 times more than what we have set. For example, if you set a brain concentration of 2 target site, the plasma site concentration goes more than 6 to 8, because the mandate is to achieve brain concentration. So for all normal patients, our intention is to take them from awake to asleep as quickly as possible. It is suitable. For example, if you have a patient with low ejection fraction, valvular heart disease, so you can start off with a plasma site targeting. So the hemodynamics will not alter. If you put an arterial line and start with plasma site targeting, start at 1, 1.5, 2, BP will not budge at all, right? But the same thing if you do in a cardiac compromised patient, you put 2.5, the plasma site will shoot up to 9 and BP will drop. So in summary, what I want to say is plasma site works, but it is very, very hemodynamically stable. The brain, the targeting takes a little slow, right? If you want a quick induction, use effect site targeting, because the mandate for the machine is to take them from awake to asleep as quickly as possible. But when we have a hemodynamically compromised patient, take them slowly, right? Even if you target brain also, you can go stepwise so that the hemodynamic stability is maintained. Did I make it
Thank
clear?
you so much. Yeah.
Yeah,
So
One
here
minute.
I would like to add
No,
something.
one
Okay,
more.
fine.
Okay,
Dr. Joseph, yeah.
yeah, no, see what I'm saying is, I take the points, and thank you, Dr. Subramaniam, for your point. So, I'm talking in terms of neuroanesthesia. Suppose
Correct.
my whole principle is to maintain cerebral perfusion pressure.
Correct.
So now here it is not about what I want. My end target is to maintain cerebral perfusion pressure. So whether it's effect side, plasma side, whatever you do, whatever is the risk value. So very often we are using now very potent drugs, like remifentanil is a very potent opioid, and you very often you get very low heart rates, and propofol causes vasodilatation as well and
Correct.
decrease myocardial contractility. So I don't want to use a dose and a model and a plasma or effect site, but the patient is hemodynamically compromised. So some of these closed loop systems, as Dr. Sethi has said, that Dr. Puri has designed and patented, they also have a vasopressor on use. So either it is norepinephrine, noradrenaline, or phenylephrine. So the fourth or third syringe is a vasopressor, which will automatically start off maintaining the blood pressure. So, so now that is the new system that are coming slowly. That will be, it is available already in India, but it's not marketed very much, I think. So this time for our conference, we had brought it to Bombay for the first time. So they have a good pump, I think, called Clarity. The city, isn't it?
Clarity, we have bought one system now. Yeah.
Yeah.
I was initially using the prototype which Dr. Puri had developed. We did a lot of studies, published 4 or 5 papers on it. So now we are using the one which is supplied by Clarity. It uses the modified Marsh model.
So I've had a close look with it. It has got because it is a closed loop monitoring the EEG and the blood pressure, it has got advantages. So we can also look at the EEG, look at the patient is talking. Instead of us interfering, the machine is interfering. So whether it is with vasopressor or the dosage, so I think what you already said is to be in touch with what is happening with the patient. At what level the patient stops talking to us.
So
When he
I think the model has to be decided as per need, that for which kind of the
Induction,
surgery
yeah.
we have to do it, and what
But
specific
with
reason.
CLAT system, you use
And
Marsh
for
model
the,
for the dose.
or for the beginner, whoever is practicing, starting the practice, they should use the plasma level, because that is the safe. And the people those has already experienced, I think they should go
Sir,
for the different
sir has to
level,
say
because
something.
they can do the alteration in the doses as per need at that particular time. Correct?
Ma'am, I will add a little bit here. No, plasma set doesn't mean it is completely safe.
Yeah.
What you need to start is start up at a step level. Even if you effect site, start with 0.5, go to 1, 1.5, 2, so that we understand how the patient is behaving. That's all.
Okay.
Okay. And initially, when I started using it, it is like induction has to be very fast, and surgeons aren't used to it. So initially, we used to induce the patient and then start the TCI, which is not the right way, I suppose. And hence, then if I'm using that way initially, just to train myself, at what dose should I start the TCI pump? Suppose I have induced with propofol, fentanyl, and cisatracurium, and now how should I start? Any case, laparoscopic cholecystectomy or hysterectomy? Joseph, sir.
Okay.
Or Subramaniam, sir. Can I do that or after induction, or it is not advisable?
Shall I answer, sir?
Yes, you want to take it. Yeah.
Sir, you take it, sir.
No. So no. See, what I'm saying is, we are going back to the same point. I suggest when you use TIVA, TCI, you must have a depth of anesthesia monitor. It's not about how fast and how slow you do. Every anesthetic technique has to be done carefully, especially when you're starting off. Okay, so now suppose you're giving a regional block, for an example, you will take your time to give a good block. So it is not about keeping the surgeons happy. It is about keeping the patient safe. And if you are starting a new technique, better start slowly and you learn stepwise. So it's not about fixing. There's no magic formula. There's no magic number which I can tell you. Because I'm reiterating, it has to be specific to your patient population. The patients whom you're dealing with may be different from mine. So if you've got depth of anesthesia monitor and you've got your hemodynamics being monitored, then you use you change the levels as you see the numbers on the depth of anesthesia monitor. I use this monitor, and I normally for my cases I have an arterial line, so I'm monitoring the
Okay.
hemodynamics. Dr. Subramaniam.
Madam, I'll tell you, whole idea of target control infusion is precision in analysis. What is the level in the plasma? What is the estimated level in the brain? When we feed those value and set a target, if you can notice carefully, the machine will show how much bolus it is giving.
Yeah, yes.
Okay, so should we move for the next
So your
question?
transmission is not good, Dr. Subramaniam, sir.
Okay, fine. So now my next question goes to Dr. Subramaniam. This is a case.
Sir is
51-year-old
saying something.
had persistent sciatica pain and not responding to medical
Madam, sir is saying
treatment.
something.
Huh?
Sir is trying to say something. Sir, your connection, net connection is not good. Subramaniam, sir, your net connection is not good. No, we are not
Okay.
able to hear you, sir. We are not able to hear you. Sir, we are not able to hear you.
Okay, fine, Shilpa. We will move for the next question.
Yeah.
Let's
Okay.
connection goes on. We can ask next question to Dr. Nitin Sethi. Now,
Okay,
Dr. Nitin Sethi, this is also the case-based scenario.
Yes, ma'am.
60-year-old patient presented with weight loss, decreased appetite, and was diagnosed to have mesenteric mass. Posted for laparoscopic mass excision and lymph node dissection. Can we use TCI in simple laparoscopic cholecystectomy, hysterectomy, or cytoreduction? Is it possible?
Yes, ma'am. It's possible in all surgeries. In fact, and in my I routinely do laparoscoping and robotic in my OTs all the time. So for me, TCI is the go-to thing to do, whether it is target controlled or automated. So my thing is, whenever I'm starting the case, my first thing is, whenever starting, obviously, after you should have a good IV access and a dedicated line for giving TIVA. That is very essential. Sometimes patient comes with a 22 gauge cannula, or don't mess up with those, because your main thing is good running IV. So if obviously all those things satisfied, a BIS monitor to be attached prior to induction of anesthesia. That is not that induce kar diya and then attaching this. So once my BIS numbers come, my whether I'm using a Marsh model or a Schneider model, if it's a mostly if it's an elderly patient, by my default I like to use Schneider in the elderly patient. But you can even use Marsh. That's not an issue. Issue is, or as Dr. Subramaniam, everyone pointed out, how you start. So my is, if I am doing it, I start because remifentanil we just got recently. So I'm used to giving fentanyl all my cases. My simple recipe is I give all patients get a fentanyl around 2 to 3 mics per kg at pre-induction fentanyl is given to all the patients. I start with a concentration of 3, whether it's a plasma or effect site, I begin with 3. My baseline, I normally begin with 3. I attach the BIS monitor. Once you induce with 3, then I look at the BIS trends every 30 seconds. So every 30 seconds, 3, after 1 minute of giving your neuromuscular blocker induction, go to 3, like LOC, go to 3.5, and rarely you have to go till 4. Normally 3.5 to 2.5, the anesthesia gets induced. Because in our, I'll just give you some numbers. In a study which we just conducted, we compared Marsh, Schneider, and CLADS. Our median time to induction with the Marsh model was 1.6 minutes. With the Schneider, it was 2.3 minutes. And similarly, 2.3 minutes with CLADS and 2.1 minutes with the manual when we were using targeting the BIS of 50. This was the induction time which we got, and we took the induction dose. So, and following this, and once you're coming into the maintenance mode and once the BIS is settled, titrate the your values, your plasma or effect side values based on the BIS. That's what I routinely do. Try to maintain a target BIS of 50, and obviously taking care of the hemodynamics as we go on. And once, obviously, once you are inducing, you have an idea at what concentration your patient has had LOC. So where, suppose, because if even if you've dialed 3, it won't go to 3 immediately. You'll, when you're looking for the loss of consciousness, at say 1.8 or 2, the patient loses consciousness, and maybe at 2.83 he has that induction dose, that BIS of 50 comes. And when you're retrieving the patient out of anesthesia, so when the time they start closing the skin, or you just keep coming down on your concentrations, targeting the concentration at which the LOC was achieved, and obviously looking at the BIS values. So you have to look at everything and then retrieve the patient out of anesthesia. This is what I routinely do. And in between, my doses of fentanyl goes around, if it's a long case, suppose it's a 6-7 hours case. So first 3 hours I'm trying to give around 1 mic per kg per hour of fentanyl, then reduce it to 0.8 to 0.5 mics per kg. And that's how it goes. And that's what I've been practicing for all this time.
So all laparotomies can be done.
Yeah, everything can be done. There's no issue with any laparoscopic or robotic. There's not issue at all.
So, sir, you are giving propofol with TCI pump, and then you are using fentanyl with routine TIVA.
Routine TIVA.
This.
Yeah.
Okay. And suppose I want to add some drugs in between, or do you use inhalation agent at all, or no?
No, I don't use inhalation. No inhalation, no nitrous. It's a pure TIVA, because when we say TIVA, it's pure. It's no inhalation, no nitrous, nothing comes in the picture. So, and now you have your end of surgery, you have your nice nerve blocks, and also you give that, and it's that thing that nitrous say that analgesia effect will come and all. I really never appreciated that. So it's always, so fentanyl really takes care of everything. Now, obviously, remifentanil has recently come into our hospital, so maybe that obviously that cost issue still remains with remifentanil. So maybe that choice of patient, we have to see in whom we want to use remifentanil. Cardiac patient or a high risk elderly where you want a quick recovery and all, but most of the time fentanyl suffices, I think so. Yeah.
Okay. So should we move?
Yeah.
So, can
it be used for such cases? It was asked, ma'am. Wherever we are using IV induction, wherever we are using propofol to induce the patients, all those patients can be done safely under total intravenous anesthesia, preferably under target controlled infusion. So there is no contraindication at all. The only contraindication is when you have mitochondrial diseases. So that is when propofol is contraindicated. There are now studies which are coming up, especially Nature has published, there are 3 specific genes which have been identified, which will increase the sensitivity of the patients to the propofol medication. So once we have that, we will also have a test. You put a saliva into the beaker, it will tell you whether how much sensitive you are. You can modify your dose of propofol also. Beforehand, you can estimate what is the requirement. That is where we are reaching. Pharmacogenomics will be part of the TCI modeling, whether it is for anesthesia, whether it is for chemotherapy, whether it is for immunotherapy, whether it is for insulin therapy. Pharmacogenomics is going to be the part, and target controlled infusion will be the way which will be leading in this domain.
So Shilpa, should I ask Dr. Subramaniam next question?
Yeah, please, madam.
Okay, fine. Dr. Subramaniam, this is for you. The case scenario, a
Tell me.
51-year-old patient had sciatica, not responding to medical treatment and had progressive significant leg numbness. He was posted for microdiscectomy under local anesthesia plus TCI TIVA. If the same patient had a spinal schwannoma under general anesthesia and neurophysiological monitoring, how would TCI and TIVA differs?
Yes, I'll tell you, there are 2 different scenarios which you have given me.
Yeah.
One is whether target controlled infusion can be used for sedation.
Correct.
Absolute. So, in fact, it would be the choice of with the way sedating the patient, because they will never, because what is the idea of sedation? What is conscious sedation? When you want to talk to them, you should be able to wake them up very quickly. So propofol is a wonderful drug. The moment the concentration comes down to that level, they can talk to you. When remimazolam comes, it is even better. But for procedural sedation, the target between 0.5 to 1.5 works really well. If the local block is really working, around 1 is good enough for the target, right? So if it is more than that is required, for example, let's say you are doing just a local infiltration, you may need a little bit higher. All along, the key concern is whether is patient breathing spontaneously? Are they going to apneic episodes? If you are maintaining target controlled infusion, going up slowly, the apnea will not happen. Just like how the patient's spontaneous breathing is maintained when we go stepwise induction in propofol, in volatile, the same way here, if you are going stepwise, spontaneous ventilation will be maintained. You can use a normal, the same way use CO2 to understand around the mask, whether the patient is breathing regularly, is the CO2 accumulating, and the moment you reduce, they will talk to you. That is for the sedation purpose, right? Now, the next thing for when neurophysiological monitoring,
Sir,
we
can I
all
interrupt?
know.
Sir, can I interrupt? So
Please,
it is just the
please,
propofol, or you want to give pre-medication also before propofol?
Ma'am, pre-medication, why do we need to give? To reduce secretions?
Or means, I mean the fentanyl or
if
midazolam or nothing? Just the
there is
propofol.
pain, if the block is, for example, let's say I've done a fantastic ESP block for this case.
Okay.
So there is no need to give fentanyl. If you want to give 25, 50, that is fine. It is still intravenous anesthesia only, right? Supplemented with block and sedation. So we should not give in a dose that it can knock the respiration off. Right? If you're, let's say you're even a TKR also you're doing. So you're given a fantastic spinal where the entire lower part of the body is numb. All you need to do is to keep the brain asleep. Brain is half asleep because there is differentiation happening from that lower part of the area. You will need a smaller dose. So if you want to go up the sedation, go up by small amounts, keep a track so that the breathing rate can be monitored. The CO2 can also be monitored. So that is the way I think it's forward to use target controlled infusion for sedation. Now, what are the drugs which are suitable for target controlled infusion sedation? You can use propofol up to 1, 1.5, up to 2 also can be used very, very safely. You can also use remifentanil in lower concentrations if you want to. So, and fentanyl, it doesn't make it suitable for target controlled infusion for sedation. For pain relief, yes, there are models which I described that. But the 2 commonest drugs which are used for procedural sedation is propofol, you can use remifentanil. There are models available. Dexmedetomidine, yes. Dexmedetomidine wonderfully works because there are now models which can accommodate according to weight. It is still plasma targeting because we don't know where exactly is the target organ for the dexmedetomidine. So as a result, you can use dexmedetomidine. It will not stop breathing. So the drugs which are useful for procedural sedation as TCI, I strongly feel dexmed, you can use propofol, and if you're slowly comfortable, you can use remifentanil also.
What about ketamine, Dr. Subramaniam? What about
ketamine also is their model, ma'am. I personally don't have experience with ketamine for sedation. I have used ketamine for anesthesia. So, but there the BIS is not reliable. When you use ketamine, the BIS becomes a bit unreliable there. So you have to use other indicators to ensure that the patient is asleep. Other clinical indicators. What do we do when we give inhalation anesthesia? We keep everything under observation so that we monitor the heart rate, we monitor the blood pressure, we monitor the SpO2, breathing, all those things. The same thing needs to be done. Doesn't mean that moment we give anesthesia, we forget all those things. We keep all those things alive and keep the clinical context and use the dose appropriately. So especially when we use ketamine. So, but what drugs are suitable for TCI? Definitely propofol, definitely remifentanil. Fentanyl can be used. Dexmed is wonderful. Occasionally, I've used midazolam also as sedation for TCI. For example, the patients have come with huge anxiety for getting into the MRI suite. So we used long extension, use midazolam also. And because we are giving a right dose at the right time, not before and not after, so they wake up very well, absolutely very well. Now, when we go into surgery, so the key thing is during surgery, during the anesthesia, deep anesthesia, we should use medications which doesn't affect the measurement of SSEP and motor aortic potential. So what are the drugs which doesn't affect volatile effects? So what we do, opioids, that means remifentanil, short acting, and propofol in a reasonable amount works fantastically. I'm sure Dr. Joseph has a wonderful experience with that. We can hear from him.
Thank you, Dr. Subramaniam. Now, Shilpa wants to ask.
Yeah, Joseph sir wants to add something. Yeah.
Now, see, the point is the panel is, we are a little compressed for time and the questions are going all over. So we just add to each other's. So now, if you specifically microdiscectomy, Dr. Subramanian has spoken very well. But if you are using neurophysiological monitoring for spine surgery, then keep aside sedation, suppose I'm giving general anesthesia. Then we use propofol, remifentanil, depth of anesthesia monitoring. Okay. And the important thing is you asked a question about ketamine. So ketamine is very good in pediatric patients. Ketamine is known to increase the size and the amplitude of the MEP. So it is a very good drug to use. I think ketamine is a much malign drug. It is always considered a foe in neuroanesthesia because it causes raised cerebral blood flow. But actually, ketamine can be your friend. But you should use it well. Now, it doesn't matter which drug you use, but it has how you use it that matters. So I take the advantages of each drug that I have and I underplay the disadvantages. So ketamine has got its own good role because it produces good analgesia. If you're using ketamine, use a very small dose, 0.3 to 0.5 milligram per kg per hour. This will give you excellent analgesia post-operatively also. It acts for a little longer time. It will overcome the hyperalgesia that you have with remifentanil. So you must basically give a good multimodal role. So ketamine can be used, especially in spine surgery, and especially I use it in pediatric population. Okay, now and I just want to say a few words about remifentanil. We have been using it. I've used it very long ago when I was in the UK. Now people talk about the cost, but I say that in euro anesthesia, I look at the value. So in the end of that case, I want my patient to be woken up and I want him answering the questions which we do normally at the end of the neurosurgical procedure, that is moving all the four limbs, and then even speaking his or her name or saying a few words that we want. So if they don't say that and they don't do that, the doubt may come in my mind, should I take this patient to the CT scan? But if they wake up completely, and I also advocate the use of a TOF monitor for TCI TIVA. So when I see all the four twitches there, at the end of the surgery, I give Sugama Dex. The dose of the Sugama Dex depends upon the TOF monitor which you're using. So use depth of anesthesia. I use TOF monitoring for every case. So you can objectify and rationalize the choice of drug. So I don't mind. And remifentanil, if you use remifentanil, the amount of propofol you require is less. It is so
Okay.
potent. So automatically you make some cost savings there too. But in the end of the day's play, I want a clear-headed recovery. So my neurosurgeons are now addicted to this drug. So if you don't use it, they say, "Kya ho gaya aaj?" So if somebody else doesn't use it, but only thing is getting it into the theater, into the hospital, and it's a little difficult because of the licenses that are involved. So I feel use the drug well, and you'll be save money in the other drugs that you use.
I'm
There are some
using
questions.
remifentanil and propofol for interventional neurosurgical procedures in cath
Yes,
lab when they
yes,
are
yes.
doing it for DSA. And I found it is really a wonderful drug, and I'm very happy that all my patients are doing well, because critically they are ill, hemodynamically they are unstable, and consciousness level is also not that good. So this technique really works well in for DSA patients in cath lab. And I'm using remifentanil TIVA for cath lab procedures for PTCA cases. And for
Oh.
PTCA cath lab cases, they are really doing well. So I advocate for those cases also, not only for the neurosurgical procedure or other surgical procedure. Even cardiac patients are doing well with this technique.
And don't
Yeah.
forget to use paracetamol. Don't forget to use your NSAID. Don't forget to use the regional block.
Yeah, they
So
are,
it
they are
should not be
Yes,
only
yes.
IV meals. Don't stop your other good anesthesia techniques that you've
correct,
got.
correct, correct.
A good regional block given, ultrasound guided regional block, or you
Yes,
can use. I use plenty of paracetamol up to the safe dose, NSAIDs, because all these things will help to reduce the dose that you require, and it
correct,
will prevent that pain. Everybody talks
correct,
about hyperalgesia. Patient comes in. So my end case is I want my patient to be awake, comfortable. I don't want him to be awake and crying. So I
correct.
want the patient to be awake and comfortable. So it's all how you plan your anesthesia and titrate it.
Okay. Subramaniam, sir, you want to add something?
Two important points came up. I'll add another one. One is when you use it in cath lab and those cases, we want quick recovery, right?
Mm.
So at the end of the procedure, we want wake up. So that is the beauty of remifentanil. Sir told about neurosurgery. Even when the brain is operated, the patient wake up. The secret ingredient there is remifentanil is metabolized irrespective of the duration of use, right? Whether you use it for 1 hour, you stop it at 7 minutes, patient, there is no effect of it. You use for 10 hours, even when there's deep stimulus, going around the nerve, doing screws, intensely stimulating peritoneum, whatever it is, you used it for 10 hours, you stop it, in 7 minutes, the effect of the drug is gone. So if the patient is asleep, it is not because of the opioid. That amount of assurance is there with remifentanil. So that is it. And if you want deep analgesia in certain points, you can give it. You want light, you can make it light. So in that way, that titrability is there. Whether you want deep or light, that flexibility is there. That is the beauty of remifentanil. That is why I feel it's a very, very powerful attend. For example, if you are having a powerful vehicle, SUV with you, you can go in a normal road at a normal speed also. In a highway, you can drive at a speed what you want. That is like an SUV. You can go fast, you can go slow, but still you can have a control of what you want.
Yes, thank you so much. Points are getting clearly cleared up. Dr. Sethi, sir, Nitin, sir, this question is for you. We have a male 56-year-old with hoarseness of voice and was diagnosed to have vocal cord growth and was posted for microlaryngoscopic laser resection of tumor. The plan was to put microlaryngoscope laser specific endotracheal tube. So I would know whether TCI TIVA should be used in these cases, because see, at some point they will ask us to reduce anyway the nitrous oxide. They will ask us to decrease the oxygen concentration to 21% to 30%. So how do you suppose? How do you do these cases like?
Look, now I think obviously the trend now has come, now people advocating tubeless surgeries for microlaryngeal surgeries and all. Earlier, obviously, most of the time, obviously, we are using a small size tube and using, people tend to use inhalation, and but that depth is not adequate. You, because most of these patients are, they are, most of these
patient profile is. There may be OSA, there may be obese, they are smokers, they are hypertensive. That's what this profile of these MLS patient comes. And the BP running, blood pressure running all around when the stimulus comes. So that with inhalation, that titrability, I believe, does not come. But then again, even if you're suppose not using, forget tubeless surgery, even if you're not comfortable with tubeless, you're using a microlaryngeal tube and getting these surgeries done, then with using a combination of propofol and remifentanil would give you a good anesthesia depth, a good analgesia, and good hemodynamic management also. And then the recovery and titratability can be done, because looking at the patient profile, the OSA patient, these majority of them have these OSA issues, and you use too much of inhalation, then you're getting airway obstruction post-operatively. So with using TIVA, you can get away with these things. You can titrate your depth better. Now, coming to the tubeless surgeries, which many people do tend to use, therein we have to be very careful what patient you're choosing. You cannot take every patient and let me do a tubeless surgery in this, because again, the patient profile has to be, his airway has to be good. He should not have any underlying OSA and all, because you will not be intubating this patient. You will be just monitoring his oxygen saturation. And I don't know, nobody will be doing ABGs quite frequently, though they recommend that if you're doing a tubeless surgery, you should have a way of monitoring your CO2 levels. So obviously literature says do CO2, ABG and CO2 monitoring, which won't be possible. I know in daily practice it won't be possible. So if you're planning for tubeless, your choice of patient whom you're going to, because the surgery duration should not be more than 10 to 15 minutes, because you'll be using the normal way of going out is you give your TCI propofol, you start with, obviously with base monitoring. Remifentanil, you can start with ranging between 2 to 5 nanograms per ml, or increase the concentration when they're doing the instrumentation and all. And you give a dose of neuromuscular blocker, and you use a HFNO norm is recommended. Like you start with the HFNO preoperatively and increase the flow rate of HFNO during the course of surgery, so that or Thrive, whatever you're using, so that the ventilatory exchange is there. In our practice, in our institution, we use jet ventilation. We have a jet ventilation catheter, which we use manually, high flow of air, and through their instrument, we pass that jet ventilation tube and manually look at the chest rise. So that duration, because obviously CO2 monitoring is hampered when you're going for tubeless or jet ventilation thing. So your duration of surgery has to be quite specific, and your choice of patient has to be quite specific. Rest, the course of anesthesia will remain the same. You can use your remifentanil and propofol, increase the dose when they are doing the manipulation part, and then the recovery will be very good as compared to inhalation.
So both the drugs you are using in TCI model only, or like then we should have two pumps?
Currently, obviously, I've not started using remifentanil. It's just come a few, I think a month back only. ENT surgeries I do off and on only, not on a regular basis. So even if I'm doing it was using fentanyl and going along with the propofol. So with fentanyl, starting with 2 to 3 mics per kg, it's a short duration surgery. So one dose of fentanyl suffices, and maybe if the intraoperatively hemodynamics are getting disturbed, you can just supplement your fentanyl, and maintaining a anesthesia depth around 45 to 50 of base titrating propofol according to maintain the depth around 45 to 50, and then retrieving at the end of surgery by coming down. So with remifentanil, obviously that titration advantage will be there. You can really titrate to dose, and patient will wake up fast, as all our esteemed panelists have discussed about it, whatever the duration it is. So remifentanil will obviously give you need 2 TCI pumps. I think it's better to give remifentanil with a TCI pump rather than with manual infusion pumps, you titrating the dose, because your effect site concentration will be exacting what you'll be achieving when you're using a TCI pump rather than a manual infusion.
Okay, can we move on to the next question? You want to add something, sir?
No.
Yes, sir.
Dr. Sethi has made it very clear. Hypnosis maintained by propofol, pain relief maintained by remifentanil, muscle relaxant made by muscle relaxant. Right? All these things are taken care of. But we need to make sure that oxygenation is going on, CO2 is being taken out. So how much time we have to assess that is the question with these cases. And because there are three different important points here. The stimulus, what happens, is not constant. So when you do direct laryngoscopy, intense stimulus is there. When the vocal cord is being stimulated, intense stimulus is there. Now, which gives you the flexibility to increase or decrease this without dialing, without increasing the flow, making that surgeon asleep? IV. So you have got propofol, remifentanil, which can give you ability to titrate deep and light. And this is the technique of choice in this case. How you maintain oxygenation and remove CO2 is another question. Whether you want to put a tubeless, depending on the case scenario, you have to choose the appropriate technique. But keeping them asleep is possible with IV. Giving them pain relief is possible. Giving them muscle relaxation so that vocal cord doesn't contract is obvious there. So,
okay, thank you. Next question is for Joseph, sir. This must be one of the favorite sirs. Joseph, sir, we have a 61-year-old male patient with headache, nausea, and sudden incoherent speech, and was diagnosed to have glioblastoma situated in the temporal region extending into the vernix area, the language comprehensive area. So awake craniotomy was planned without intubation. Can you help us how to go about it with TCI TIVA? Joseph, sir?
Yeah. So one common thing I want to bring out is that we have discussed so many cases. So I already spoke about maintaining the basic principles of anesthesia. I already spoke about cerebral perfusion pressure. So I think rather than choosing the technique, one must choose your patient well. Now, once we come to an awake craniotomy, patient selection is important. So if it is a potentially difficult airway, or if the patient has got some abnormal movements, or he's got a physiologically or anatomically challenging airway, and if the patient is not cooperative, so then, or if it is a child who's not going to cooperate with you, then you may have to rethink whether you're going to go for the awake craniotomy or not. If you've got a patient who's still convulsing, so it's important you choose the patient, counsel the patient. And if you ask me, the cornerstone for my technique of awake craniotomy is the scalp nerve block. So here I'm going back again. So that is the cornerstone. All the other drugs that we use for conscious sedation have evolved over time. So first it was the neurolab technique, which was long given up. Then came propofol. But propofol, as I already mentioned, the disadvantages you all know, it can also cause a compromise of the airway. So when the patient is undergoing awake craniotomy, sudden loss of an airway can be disastrous. So choosing a patient is important. And now see, suppose propofol also causes peripheral vasodilatation. It may cause hypotension, which may be difficult to deal with in a patient who's awake. It is also known to be epileptogenic in some doses. So we moved on then to dexmedetomidine. Dexmedetomidine is a wonderful drug because it maintains hemodynamic stability and maintains respiration well. But I lost interest in it a little because it went out of favor, because it has got a little bit of prolonged action. So you may start it, but as Dr. Subramaniam mentioned, the context-sensitive half-life of remifentanil is just 6 to 8 minutes because it has got a linear pharmacokinetics. So if you see the plot, fentanyl will be standing this way and remifentanil will be always straight line because it is metabolized by the plasma esterases. So you will not get that pharmacokinetics in any other drug. So remifentanil now is my drug of choice if I have to supplement, because when I stop the drug and I start the testing, I want my patient to be more awake than sedated. If you develop a good rapport with the patient, I give realistic expectations to the patient. So I don't want my patient to be sedated when the testing is going on. So it's important that I give realistic expectations that you may hear some sounds, you may feel some pressure, you may be a little uncomfortable, not necessarily in the area being operated, because once you open the dura, it's a painless surgery. It is just the removal of the bone flap and the retractions that may be sometimes thing. So it's also important, there are surgeon factors. So the surgeon also should be skilled and little gentle. He should also explain that, abhi main drill karne wala hu, something like that. Tell the patient what's going on. So that communication is very much key. The use of your drug depends once again, as I'm mentioning, to what you got available with you. Dr. Sethi himself said, now he's working in Gangaram, they've just got it. I know how much we have struggled to get remifentanil. Now I can use it. But otherwise, as he said, a well-used fentanyl also has served the purpose. Small titrated doses. Here the key is titrating doses according to the surgical step. So it's also important to keep a watch on the surgical step. It's important that your colleagues know the various surgical steps so you can titrate your dose accordingly. If you set a syringe pump on, the syringe pump doesn't know the surgical steps. They don't know when they're going to drill the bone or when they're going to make the burr hole or when they're going to use. So that time you will have to change the concentration on this. If you're using a normal pump, I can see there's a question here. How safe it is to use normal syringe pumps if you don't have CCI pump. Now, whether you got a TCI pump or you got a syringe pump, those pumps don't know the surgical steps. They don't know the analgesic requirement at various stages of the surgery. So that's important thing to use. So, but if you ask me, my technique of choice will be focused on the scalp nerve block given well. I will once again speak about multimodal analgesia with paracetamol, NSAIDs, and I use remifentanil now because I can switch it off within 5 or 6 minutes. And sometimes I keep a very small dose on, just 1 nanogram per ml the dose. So that is it's fantastic because the patient is comfortable, but he's communicating well. There's no loss of
Oh,
so a small dose. And in fact, towards the end, in neurosurgical procedures, not awake craniotomy, I keep it on till the pins are removed. And I may keep it on till the dressing is being applied. Because once you stop it, I'm sure he'll be.
yeah.
And
Yes.
see, I also tell my surgeons, you have taken 4 hours, so give me 15 minutes. We are not running a race here. It should be a fair race. तुमने 1 घंटा लिया बंद करने के लिए, the junior, so give me 5 minutes. So if you use
Yeah.
sevoflurane well, if you use fentanyl very well, that's all you require. So communicate with us, and the surgeons should. You develop the rapport after some time. They will also. They don't come there when I'm extubating my patient or because they know this person is going to wake up. So
Okay, so your
you demand your
recipe is
15 minutes.
remifentanil.
Huh?
Your recipe nowadays is remifentanil.
But no, the scalp nerve block with
And
remifentanil.
remifentanil and multimodal. Okay,
If
so
you have
not
got XM, you can use it. I have stopped using it, but that is also a good drug. But I told you, you know your pharmacology very well. So the half-life of dexmedetomidine is how much? Is about 1 hour. So sometimes they still remain a little drowsy. They may be pain-free.
And you don't, along with remifentanil, you don't use low dose propofol.
No, I don't.
Don't use.
I just mentioned earlier that remifentanil has decreased the requirement of propofol for general anesthesia. So if you use it well, it's very potent. It will. So in fact, I did one paladotomy. I'll just add to this. So I did a paladotomy, it's a deep brain stimulation case where the scalp,
Okay.
and I used remifentanil. I intubated the patient because here they wanted the patient to be intubated but cooperating. So I intubated the patient, remifentanil, just a touch of propofol. I think we overuse our muscle relaxants also a lot. So, and the patient tolerated the tube with the low dose of remifentanil going on. And when I wanted him to respond, he opened his eyes, showed the tongue, moved his hands and everything. So I used it both for tubed awake craniotomy and awake craniotomy.
Okay, and for asleep craniotomy, suppose I want to do neuromonitoring, then what would you use? Still the remifentanil one, or suppose I don't have remifentanil, then?
Then I will, okay, you're going to do, so then I will use, but is awake craniotomy again?
Yeah,
Awake
we are going
craniotomy
to
again?
asleep, awake, asleep.
I'll use scalp nerve block and I will use fentanyl, titrated doses.
So you prefer fentanyl instead of dexmedetomidine?
No, I will go with the fentanyl. A titrated dose of fentanyl.
Okay.
And you must time it well.
Dr. Sethi wants to add something, or Subramaniam, sir?
Because we used dexmedetomidine in one of us in laparoscopic. What we found was post-operatively that hemodynamic effect, especially bradycardia, Like in the recovery room, what persistent 1 hour, 1.5 hours, and you really need to monitor these patients because that your sisters get jittery. They keep on calling you, oh, patient ko abhi bradycardia chal raha hai, chal raha hai. Sometimes, so that discharge gets delayed because I feel with dexmedetomidine, whatever the advantage may be giving.
Okay.
So that thing is there with dexmedetomidine. I found out that, and whether how much pain relief it is giving, we really found it. I find it quite questionable whether we're using it as a.
So I will quickly add here now, we are talking such a lot about TCI, TIVA. Some basic principles I think we should cover, that you must have a dedicated line for remifentanil. You must have an anti-siphon valve. See, these important things also have to come out in this panel. So I'm just saying, I always put a dedicated line for, I don't mix drugs. So if I'm using Remi, I will take another separate line with the anti-siphon valve. These are important things. You must
Okay.
make sure your connections are there.
No IV connection, no IV fluid running in that.
If only IV fluid going, it's okay, but I will not give another drug in that.
The IV fluid going is okay.
Yeah, IV fluid maybe just
And
like a flush.
extension should be the thinner one, arterial line extension, or the
The
routine extension.
arterial line extension I use, the pressure line.
Yeah, yeah.
Okay, then it's important that after you finish, you flush that line because you don't want the patient to go to the recovery room and somebody flushes it.
That reminds me, what
Yeah.
haunts me is when last 10 cc is remaining, there is always an alarm, syringe empty. What do you do during that time?
Okay, so now it's very important that you don't switch off the pump and start it again. You just pause it, refill the syringe and refill the syringe.
Like
if you
suppose
switch it off,
I'm done, last 15-20 minutes are remaining.
last 15 minutes.
Or maybe last half an hour. And how to use that 10 cc drug? You have to waste it, or?
No, I didn't get the question, but Dr. Subramaniam wants to see.
Shilpa, I can add you there. All these advanced pumps, no, it has a syringe recognizing capacity. So if you notice 50 ml syringe is not 50 ml capacity, it is 60 ml syringe, right? So if you look down in that, when you choose which syringe is there, choose a syringe which shows 50 and has 60 capacity in those lines. Because we don't, if you're using BD exactly the same, it will not give alarm at all. Falling short of it,
okay.
Select your syringe, look at the picture there, it shows 50 with 60 ml gradations, and use that. That will stop giving you the alarms. Selecting,
because
there are 4 or 5 choices when you select the syringe, because automatically they will select the syringe size, syringe brand also. So you choose the one which is closest to what you are using, syringe part. So in that way, that last 10 ml, every time you have to fill before 10 ml itself, that alarm will stop.
Okay.
I will also add here, please, that I use lower lock syringes, so that you screw on the lower lock syringe so that the disconnection doesn't occur. Otherwise, your pump will be going, but your connection will be lost, and you will be none the wiser. And I always keep that IV in sight so that I can see whether it is disconnected, whether it's leaking on the flow. And so this is also another important thing to keep in mind. So a use of a lower lock syringe, pressure lines, and dedicated lines. These are, and I draw my drugs myself. I do not give it to somebody else to draw, because suppose I have drawn up 2 milligrams of remifentanil, I will make sure there's 2 milligrams of remifentanil. I will dilute it myself, and then I will label it. Because some people, if you give it to somebody else, you can trust them, but I prefer to draw it up myself because I know the concentration. Somebody may make 1 milligram and 40 cc and give it to me, and then it may not act according to all your models. So when I'm using 2 milligrams in 40 cc or the 1 milligram in whatever, you do it yourself, and then you put the label, so you're 100% sure that of what you're using.
Yeah. Yes, Subramaniam sir.
Joseph sir, you highlighted the safe practice of TCI. Wonderful. So preparing the drugs under supervision or by yourself, using lower lock syringes, use syringe pump at the same level as the blood, use a low residual volume extension line, preferably PM line. Don't use a 200 centimeter extension, which is used for IV, because it has got a lot of dead space. And in the pump, there are a lot of information which you can get from the pump. What I also feel is important is we should look at what is the pressure settings. When you have started the infusion, look at the pressure settings. The pumps can give you alarm when there is disconnection, when the pressure increases, when the pressure decreases, it all can be identified. So very important to know how to set that. So also there are other smart features like decrement concentration or awake concentration, start using it effectively. Wherever you have anti-reflux and one-way valve, please use it. And mixing of the two drugs. For example, let's say if two people, husband and wife, are sitting, you are talking the same thing, but each one takes it in a different way. It is not uncommon, isn't it? The same way here, it is not possible to separate hypnosis from analgesia. So if you combine those two, just like husband and wife or boyfriend and girlfriend, they can never be in the same plane. One will be in a different plane, other will be in a different plane. So somebody will get upset if you do a joke. So that is natural with people also, with drugs also.
Oh,
One more
thank you
feature,
so much. Over
uh,
to you, Manjula, madam.
yeah, sorry, just one more feature because
Yeah.
for young people who are what sometimes happens is when you're using long lines, suppose it's a robotic case, head on your lines, you took long lines you are using, and sometimes what people tend to do is your connection should be at the IV point. It should not be like you're using a long length needle and you're connecting in the your propofol 100 meters away, 20 meters away from where your IV,
Okay.
and then
Yes,
you
yes, yes.
give a fluid bolus and a bolus of drug will go inside. So any intravenous drug which you're using, it has to be at the point of where your cannula is inserted, not away from the patient. Because many times I see with relaxants, people trying to use. Induce the patient is raped, now they're attaching muscle relaxant, it is attached far away from where your IV access is. And it can happen with any adjuvant drug also which you are using. So that should be avoided at any cost. Well, that's a very common thing you see with young people just doing it. So that's what I just wanted to add.
Yeah. Over to you, Manjula, madam.
Okay, so thank you, Shilpa. I think the time has come. We have to conclude the session. So,
Madam, just a few quick questions. Robotic, I think we discussed. Laparoscopic onco. I wanted to know about chronic subdural hematoma. I just want to know that the patients are usually drowsy, but still, I have done one case with TCI TIVA, and the patient drastically improved on table itself. Post recovery, the patient was more conscious. So, is it good to do chronic subdural with TCI TIVA? Any one of you can take. Joseph, sir.
As I mentioned to you, depends upon how drowsy the patient is or not. But we normally do ours under local anesthesia, or well given local anesthesia. You can give a scalp block, and
Okay.
we can. So I will prefer to use. I'll see. I will evaluate the patient, select the patient, and do my technique. So I will not give a recipe for all subdural hematomas because we
Okay.
cannot go with anecdotal evidence. So I will still say I will prefer my patient to be awake with a scalp block.
Okay, fine.
yeah, I think a
And
scalp block really works well. Yeah, it works well.
so this is
Now,
the
I
last
think
question,
this is
madam.
the last question to Dr. Subramaniam, that if we have to do the bronchoscopy and biopsy, can we do under TIVA?
TCI.
Or
It
if
And
the
is
or
same
VATS
patient
and
comes for the VETS procedure, can we proceed? Or if the patient is for transthoracic lung resection, can we do it? So there are
this is
three questions in one.
for all three very simple answer, ma'am. TIVA, TCI is the technique of choice. You will take away what is going into the lungs, from the lungs going into the blood to the brain directly, because you are giving hypnosis, you are giving muscle relaxant, you are giving pain relief all through the IV. For VATS, I would add another component, that is a block, thoracoscopic lung
block.
resistance and block, because the pain will be reduced. For bronchoscopic biopsy, I will not do a block. So this is a very, very easy question to answer, because ventilation of the lung, all those things to keep the patient asleep is gone. The next is only about keeping the oxygenation and taking the CO2 out. What also is benefit is, we all know, when you're doing a lung surgery, the shunt fraction, you have to keep it in mind. So volatiles, what do? They increase the shunt fraction because it depresses the pulmonary vasoconstriction. So propofol doesn't have any effect on chronic HPV as well. So as a result, it is the technique of choice. If you want to use blocks, thoracic wall blocks, it makes it even more sufficient. And we, again, as I told, using drugs like remifentanil gives you a choice to deepen or lighten as quickly as possible. So when the thoracotomy is being done, you can increase the depth by increasing the. So the to keep it short, it is the technique of choice and we should use it. And keeping the FiO2 concentrations less than 60 is much preferable, very much possible with use of TCI technique.
So basically, blocks and remifentanil can be used for
blocks
best
and keeping
technique.
patient asleep with propofol, pain relief with remifentanil, titrate it accordingly. Muscle relaxant, your choice, whether you want to use rocuronium or
Nitin sir, you want to summarize? What would you give a take-home message to our viewers?
Audience.
To
Yeah,
summarize, I
audience.
think if you are using TIVA, TCI technique, it's like obviously that learning curve is there. You cannot, you have to, learn the basic intricacies. You have to have a good knowledge about the pharmacological models. You cannot just jump in. So a good knowledge of the pharmacological models, what are the multi-compartment models, your understanding what is plasma and what is effect site and why to choose what is the advantage of having an effect site and which model to use in which patient. You suppose it's an obese patient, you cannot just jump in with Marsh model in an obese patient. You dial in 120 kilos and use Marsh model, God knows how much drug will go. So even your dosing scalars, you have to know. Obese patients, we tend to use adjusted body weight for propofol. So that thing has to, if you're using your shortcomings of all models, like Schneider model won't work in a very high BMI patients. So now these pumps have a safety feature that you cannot dial in a high BMI because then it leads to overdosing in obese because of the lean body mass calculation. So what the knowledge of models is very essential when you're using. And then what are the safe practices? For me, you have to use a depth of anesthesia monitoring whenever it is available and whenever you can use it. Then all your safety features, you're having a dedicated IV access, as Dr. Joseph sir rightly said, having a dedicated line with the anti-siphon valve so that the drug does not just leak in from your system into the patient venous access, having an anti-reflux valve if you're using a running IV line along with it, and to know how to come down, as sir pointed out, like your decremental half-life. You should be aware when you're just not dial, you should be aware at what point your patient has had LOC. Well, if you're dialing it, say 3 or 4, you have to, the pump shows 1.5, 1. Gradually it shows what plasma concentration it is achieving and at what plasma concentration the patient has at LOC. So that will give you an idea when you're going to wake up the patient at what LOC, at what I should come down, and so that, and looking at your base numbers and all. So a working knowledge, a good knowledge of everything before you just jump into it.
For this technique.
Yeah, technique.
Yeah, Manjula madam, I'll just check 1 or 2 questions. Like TCI has fixed models for variable individuals. We had business we have taken already. Can we prevent intraoperative awareness using EEG? This we have taken. Then hybrid technique, if you don't have TCI pumps, that we have already discussed. And hybrid technique, and we adjust doses. How do we adjust doses if we are using dexmedetomidine, midas, ketamine, and multiple drugs?
I think don't use too many adjuvants together. You can't use ketamine and dexmedetomidine and propofol all together. It will be a big, I don't know what you'll be.
Yeah, one question which I missed, is there any synergy if I'm using TCI pump of propofol and TCI pump of this remifentanil along with it? I have to decrease the dose of both?
Yeah, no, but I already mentioned here that the remifentanil will decrease the amount of propofol that you require.
Okay. Yeah, you said that, sir. Yes.
It's also reflected on your BIS value, madam. So BIS value will show. So
and there is one more question they want to know: if you don't have TCI pump, then how safe it is to give with infusion pump?
So now I think we have used syringe pumps for a very long time. Now, how safe it is how safely you use that pump. We have used it safely in the past. Now, going back to this analogy of the car, now for parking of your car, you got a 360-degree camera, you got a side camera. So your parking has become better because you know exactly how safely you're going to maneuver yourself. So if you have got a TCI pump, you've got these algorithms built in, giving you some feedback which will help you to do your job better. If you are going to park it, if you are going to use only a syringe pump, you'll have to you have to determine yourself because you'll be going with your own judgment, with your experience and expertise, but you are blind. It is just your judgment. And Dr. Mahankali has said a very important thing. I am also reading a lot about genetics now. Each drug acts differently in different people. So again, I'm saying each patient is different. Going forward, genetics will tell you whether to avoid remifentanil, propofol in this patient, and that will make a world of a difference. So they will go to precision medicine. You can't hand over everything to AI. Please preserve your native intelligence, because I also see now people driving cars look only at the Google map. They get lost in the streets of Bombay. So don't forget your native intelligence. Ultimately, whether you use fancy machines, please use your better judgment. As Dr.
Yes.
Sethi said, also monitoring is important. So you have got a depth of anesthesia monitor, monitoring the hemodynamics, and there is some app called, I think, ITIVA app, which some people are using with a syringe pump. I will not recommend it, but I'm just saying somebody asked that question. So that app is free, ITIVA app. So I don't know, Dr. Mahankali, you want to add?
Sir, you highlighted a lot of fantastic things. Now, even when you have a TCI pump, you know how to use it. You have 9 times out of 10, you have access to it. In case if the pump goes wrong, you should basically know how to use normal syringe pump to give IV. That is an important exercise which needs to be met. So knowledge of the TIVA, based on weight, you still should be there in the back of your mind to use 10 milligram per kg per hour, 8 milligram per kg per hour, 6 milligram. That needs to be known. When we started this, what we had was, the idea was it will establish a plasma level of 3 microgram per ml. Instead of using that complicated equation, this TCI pumps helps you deliver. And it helps you to increase from 3 to 4, how much to give, it automatically calculates. But we should be knowing these things. The other important thing which has happened is lot of people have studied and advances have come in. I will tell you a few things. The initial models were not suitable for children. We had models for children, Kataria and PEDFuser. Now we have a general purpose model which is validated from 28 weeks post-gestational age to 88 years old. From 680 milligram weight to validated models to 186 kilos. So what are the parameters which are using? It is using not just the weight, it also using weight. It is also using age. It is also using gender. It is also using co-administration of drugs. Now, we are on the threshold of pharmacogenetics. It will be there very soon as well. So the dosing is there. Now, let's say you have somebody with 225 kilos. Can we use the same bicycle which we use in the air? We need a special bicycle or special airline seat. So we have this Uber model called as Cartines model, specifically for patients who are morbidly obese, because their blood volume is not related to their body weight. So their blood volume is related to other factors. So how the distribution happens is all been calculated. These specialist models are there for specific purpose. If you have a morbidly obese patient, we should use Cartines model or Elivel model up to 180 kilos. So for example,
They are
if
in
you
the market already, the models.
Yes, ma'am, it is there in most of the models. If not, the company can get you that. The software for the pump is there. These companies, they don't put the model. You ask them, no, I will not use this pump if you don't give. They will come and put it.
If you ask,
So,
then
because they have-
companies are putting that model and then we can
Because-
use that.
because they have to pay
bas-
royalty that they don't want to pay. No, why should we suffer? Let them put the latest models. The pump is there, the software is there. The one which needs to drive the additional model, they have to put it.
Yeah, they are
Don't
putting.
negotiate it.
If you ask, they are putting. If you ask, they are putting. So basically, our clinical observation and clinical, that judgment helps you in managing any case, whichever you are doing it. And if you have the basic knowledge about the pump and about your patient and about your disease and surgery, then you can just proceed with the better results.
With your permission, I will add a few things, ma'am.
Yeah.
A few of us who have been doing these workshops, we have come together, formed a society so that we can encourage more people to adapt it safely, discuss different scenarios. get the pump people to come and show how to use these pumps. All these are being done under the banner of IOTA. We are happy to work with any of the societies, neuro. For example, this time doing in ISOCON also, Canadian Society has invited me to come and speak to them. So all this has happened. We need to establish more workshops where people can discuss, learn from each other, and use a safe practice. So just because the automatic model has come doesn't mean that you can drive in Indian roads. So we have to learn how to drive in Indian roads, just like the same patients here. So together, I think we should be able to take this to every part of the country. The advantage is even in a remote corner of the country, in Northeast or Himalayan region also, this pump can work without affecting of the height and weight and the height at which you are living. So as a result, even in the small places also it has got a role, big place also it has a role. I have personally used it for transplants also, neuro cases. Liver transplant now, we have now studies which are published that the outcomes are better. Now,
no, I'm totally agreeing with you that if you ask the company person, they come and they put the software for any kind of the patient and any kind of the procedure. You are absolutely correct. Yeah. So should we conclude, Shilpa?
Yes, madam, your vote of thanks.
Okay, fine. So I thank all the panelists, Dr. Joseph Monteiro, Dr. Subramaniam, Dr. Nitin Sethi, and Dr. Shilpa Tiwaskar for conducting the wonderful panel on this topic. And this topic is really gaining popularity day by day. And people are really interested to know that how they can proceed and how can they go for the better results and better ways. So really thank you on behalf of ICA to all the panelists.
Thank you. Thank you very much.
Yeah, thank you, Joseph sir, Nitin sir, and Subramaniam
Joseph sir, nice to see you. Dr. Sethi, nice to see you all. Dr. Shilpa, Dr.
Yeah, thank you so much. Thank you, everybody.
Thank you.
So,
Good day, all of you.
Sanish, should we just ask the Kalyanit people to close the meeting?
Madam Jayashri madam has also joined. And,
okay, Jayashri madam, would you like to say something?
Jayashri Sood madam, are you there? Maybe
I think she left. No problem. So Swastika?
Okay. Swastika, should we go offline?
Thank you, ma'am. Thank you so much, everyone, for giving us the opportunity to host the session. Thank you. Good night to all of you.
Okay,
yeah,
good night,
Thank
everyone.
You.
Bye.
Bye. Thank you.